Hi, this is Elliot Fishman, and welcome to our latest quiz. This is February 2025. I have 10 spectacular cases to show you, and without any further ado, let's get started. The most likely diagnosis in this case is, when you look at the images, you can see the mass present. It's fatty attenuation, and it's in the region of the patient's left adrenal gland. You could look and say, well, maybe it's coming off the kidney like a renal angiomyolipoma, but it's simply pushing on the kidney, and of course, there's no renal choices here. I have made the point previously that sometimes adrenal angiomyolipomas can look like liposarcomas, and we've even seen cases of renal AMLs looking like liposarcoma. But this truly is a myelolipoma. It's fat attenuation, minimal stranding. Lymphangiomas typically are water density to about 30 Hounsfield units. This is not obviously an adenoma, and so the best diagnosis is an adrenal myelolipoma. In the 60-ish-year-old presenting with an acute abdomen, what's the most likely diagnosis? Well, when you look at the axial and coronal images, you see very impressively the markedly thickened small bowel. It's jejunum going toward ileum. The bowel is really edematous. This is not the appearance of a GI bleed. Usually that's high density. It could be in the wall, it could be intramural, but this is not the appearance of that. It's not undistended bowel. That's not the issue here. Here it's dilated with very prominent mucosal enhancement. You could think about ischemia. Ischemia has multiple different appearances, though usually the bowel wall is thickened in those situations. The most likely answer in this case, and the classic appearance of this bowel loop, is edema of the bowel, and angioedema. In this case, you have to think about different reasons for angioedema. The patient was put on recent changes in medication for the patient's high blood pressure, and so this was angioedema of the small bowel. A really, really nice case. The most likely diagnosis for the small bowel tumor is, well, we see a mass which abuts or rises from the small bowel. Looks like it's ileum. The mass is enhancing. It's solid, but it's not obstructing the bowel. So I would think about a carcinoid tumor, but I don't see desmoplastic reaction. Carcinoids are vascular. You often see a mass in the bowel and then a mass in the mesentery, but sometimes you don't see the mass in the bowel. You only see the mesenteric mass. So this is a possibility. Lymphoma typically is not vascular, so I don't like that. Adenocarcinomas are infiltrating, not exophytic, and they're usually not vascular, so I don't like that. So when you give me a mass that's mainly exophytic, that's not obstructing the bowel, and it's vascular, my best answer is going to be a gastrointestinal stromal tumor or GIST tumor, and that was precisely the answer in this case. The most likely diagnosis in this 20-ish-year-old female with pelvic pain is, well, when you look, you see a mass in the pelvis, and you realize the mass is part of the uterus. In fact, it's inside the uterus, and it's in part enhancing. No, this is not PID. You could think about an intrauterine tumor. You can see aggressive uterine tumors that are typically vascular. They can have cystic and solid components. It's something to think about, but it's really not the appearance. This is not cervical cancer. The cervix is not dilated. This is the classic appearance of an intrauterine pregnancy. Now, the patient did not know they were pregnant, and this happens to all of us a couple times a year. But it's important to be able to recognize that this is an intrauterine pregnancy and do not work the patient up any further. Maybe get an ultrasound to look for a heartbeat, things like that, but a very classic appearance of an intrauterine pregnancy. The most likely diagnosis in this patient is, well, we see a mass in the right adrenal gland. The left adrenal is normal. The mass is somewhat necrotic. It's large, it's enhancing, and it's irregular. It could be a pheochromocytoma. Pheochromocytomas can be cystic, and they're typically very vascular. It's not the appearance of an adenoma just because of the vascularity. And similarly, it's not a lymphangioma. So really, this case, you're kind of stuck with a differential diagnosis between the pheo and the primary adrenal cortical carcinoma. And this ends up, I think I have to go more with a primary ACC because pheos are usually rounder, better defined. This is more irregular, and this was a primary adrenal cortical carcinoma. The most likely diagnosis in this patient with left lower quadrant pain is, well, what do we see? We see inflamed small bowel, not inflamed large bowel, and we see inflammation into the mesentery, and we see what looks like little outpouchings with air off the small bowel. So it's not sigmoid diverticulitis because this is small bowel. This is not the typical appearance of ischemic colitis, but truthfully, in theory, I cannot exclude it since ischemic colitis and ischemic enteritis have many appearances. This is not the look of Crohn's disease, which is usually circumferential thickening. When you see these little outpouchings and you see the inflammation into the mesentery, although it's less common than sigmoid diverticulitis, you have to think about small bowel diverticulitis. And this was a great case of a perforated jejunal loop of bowel with jejunal diverticulitis. Now, the most common location just to see a diverticulum probably is the second portion of the duodenum. The most common area to get diverticulitis probably is jejunum, though jejunum and ileum are the two most common areas. It's rare to see it in the patient's duodenum. The best diagnosis in the patient with chest pain is, well, what do I see? I see a mass in the right upper lobe, and then I see a large, bulky, ulcerating tumor from the left chest wall. It does not invade bone. It's soft tissue. I could think about a sarcoma of sorts. If I saw bone involvement, I would say chondrosarcoma or osteosarcoma, though osteosarcoma typically has more matrix. It's not lymphoma, though lymphoma has many appearances. It's not lung cancer metastatic to the axilla. It's a small nodule, and yes, it could be a primary tumor, but it would be unlikely to have such a lesion as metastasis. Mesothelioma obviously arises from the pleura. This is an impressive example of an ulcerating breast cancer. The mass arose from the lateral portion of the breast, closer to the axilla, and the lung nodule is metastatic disease. So this was an ulcerating breast cancer. The most likely diagnosis in this patient with fever is, well, what do I see? I see ascites, then I see large retroperitoneal masses that look like nodes, but they seem to be infiltrating. There's no clear border, and you particularly see involvement in the region of the right kidney. The vessels are surrounded but not obstructed. This is not the appearance of lung cancer. Lung cancer can metastasize to the adrenal, to the kidneys, to the mesentery, but not with an infiltrating process like this. Peritoneal metastasis, again, ovarian cancer, processes like that, but this is not the best appearance for that. And seminoma can give you large nodes, but you would not see that perirenal infiltration you see in the patient's right kidney. The best diagnosis is B-cell lymphoma. With lymphoma, infiltration around the vessels without obstruction is seen. Lymphoma is infiltrating, and one of the most common causes for perirenal involvement is going to be B-cell lymphoma, and that was the diagnosis in this case. The most likely diagnosis in this patient with arm pain is, well, when you look at the images, you see high density around muscle into the soft tissue, and you can see it's tracking upward, and the epicenter is the antecubital fossa. Lymphoma can give you masses, but not this high density. This is not the look of an abscess, and necrotizing fasciitis shows air, not high density material. What this is then is extravasation of contrast. We need to be very careful when we inject. Make sure the IV's in correctly. You may need to test the IV. And sometimes, it happens. You need to be really, really careful. But this is the look of IV contrast extravasation. The most likely diagnosis in this patient with cough is, well, when I look carefully, I see there's a mass involving the esophagus, and it looks like the mass involves the left main stem bronchus. The mass extends for a long distance of about 8 or 9 centimeters, and there's communication from the esophagus to the trachea, to the left main stem bronchus. Now, when you have communication of fistulas, you can have foreign body doing it, but then you wouldn't explain the large mass. You can have lung cancer invading the esophagus, or you can have esophageal cancer invading the trachea. By the length of this lesion on the coronal views, you're focusing on a primary esophageal process. So it's not lung cancer. Scleroderma gives you a thickened esophagus and dilated esophagus, but not this infiltration and not the TE fistula. And lymphoma can involve the esophagus, but typically it's bulky adenopathy with secondary esophageal involvement. And the best diagnosis in this case is an esophageal cancer with a TE fistula, direct involvement of the left main stem bronchus. Anyway, those were 10 terrific cases. I hope you enjoyed them. I hope you got them right. And whether you got them right or got them wrong, I hope you learned something. And with that, have a great day, everybody. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.